Hi to everybody who's entered. I think we'll wait maybe one more minute before we start our program.
Sucking it in.
For those of you who just joined us, I'm going to wait probably one more minute. Okay, I think we'll go ahead and get started. I have a couple minutes past the hour, and in this Zoom age, we've been starting things on time. So let's do it. I want to welcome everybody to Chemicals, Pollution, and Pregnancy. We've been having these conferences every year. We skipped last year, so we're really happy to have everybody here this year. This conference is sponsored by the Pediatric Environmental Health Specialty Unit at the University of Illinois Chicago School of Public Health, and I'll be explaining a little bit about what the PASU is in a little bit. Our co-hosts are the OBGYN department from the College of Medicine. And on this slide, I wanted to explain a little bit about the different logos. So PASU is the national name of the program that's sponsored by the EPA and the Agency for Toxic Substances and Disease Registry. There are 10 around the country. Sorry, I'm a little distracted seeing all these people become and get admitted. There are 10 centers around the country, and our center at UIC is called the Great Lakes Center for Children's Environmental Health. So we use those two logos for our local center and for the national network. My name is Susan Buchanan. I am the director of the PASU in Region 5. I am clinical associate professor at UIC in environmental occupational health sciences. I'm an occupational medicine physician. I was a family medicine physician for 10 years and did low risk OB. It's always been my interest, the effect of environmental chemicals on pregnancy. So once again, we're really happy that you're here. I'm going to go through a few housekeeping items. We have muted everybody. We do have an IT professional working with us today who has everybody muted because it's a large group. So we are going to be using the chat. If you haven't used the chat before, at least on my screen, when I move my cursor to the top of the screen, a taskbar comes down that includes the chat. So you can click on the chat to enter your questions. So we'll be monitoring the chat instead of unmuting people for questions. We're also going to put in the chat a link to e-resources. So, you know, when you go to a conference and you get your nice folder with all your background information. So we have put together background information for you that's going to be accessible electronically. So once again, that link will be in the chat for the electronic resources, the resource packet. Now, just for a second, I'm going to turn this over to Marilyn Bingham, who is the guru for continuing education for our center. So if Marilyn, I know you wanted to give people a few instructions. You want to go ahead and do that now?
Hello, everybody. My name is Marilyn Bingham, and I work with Susan Buchanan, Dr. Buchanan, and I work with the Great Lakes Center for Occupational Health and Safety. I'm the program coordinator. So I'm the young lady who applied for the continuing education credits for this conference. And for this conference, it was approved for 1.75 credits. So all physicians and nurses who would like continuing education credits, there will be a survey. The survey was sent to you by way of email when you got the Zoom link. We're also going to send it out again to make certain you receive it. But I do want to tell you that, inform you that everybody, all the planning committee and all the speakers who are speaking at this conference have submitted a disclosure form indicating that they have nothing to disclose at this conference. So if you have any questions regarding registration or continuing education, I'm going to put my email address in the chat box, and then you can contact me. And at the end of the conference, you're also going to get that cartridge survey link. You have to complete it in order to get CME, and you have to stay on for the entire conference to get 1.75 credit. So I'm going to turn it over. Thank you, everybody.
Thank you, Marilyn. We're now just going to have a few words from our co-host, Dr. Catalin Buhimski. He is currently the Director of Maternal Fetal Medicine Division and the interim head of the Department of OBGYN at UIC, so University of Illinois at Chicago, where we are holding this conference. So prior to that, he was director of the MFM section at Yale and the Ohio State University. He's published over 180 original research articles, 20 book chapters, and is co-editor of the Drugs for Pregnant and Lactating Women textbook. So Dr. Buhimski, I think you had some slides that you wanted to share, so why don't you go ahead?
Thank you so much, Susan, and thank you very much for having me. I'm just curious, what do you see at this point?
Oh, let me stop. I need to stop sharing, right, Mike? Now you should be able to share, Dr. Buhimski.
Do you see my slides?
No. So you're clicking on share screen, and then you're clicking on your slides and then hitting share. Looks like we're starting. There we go. And just put it into presentation mode and you're all set.
Yes. Do you see it now?
Beautiful.
Okay.
Go
So,
to display settings and swap the display.
Yeah, so thank you very much. It is a great pleasure to be part of this conference, and I think it's very well known for this audience that the human development and parturition, it is a very, very complex process. But on the other side, so is the process of adapting to the extrauterine life and growth after birth. I think also very well known for the entire audience is that one of the most critical time in human development, and during human development, it's in between week 4 and weeks. That is the process, and this is the time when the process of organogenesis is initiated, but also completed. In medicine, we know also, and especially in the field of maternal fetal medicine, we know that in these critical times, teratogens, they can play a critical role in inducing irreversible damage for the embryo at the very beginning, but also for the fetus. It is also very important to know that to cause a birth defect, teratogen must act during a critical time of this development, and there are a variety of teratogens that they are well recognized in the OB world and in human development, with specific focus for this conference. And my colleagues will focus on the environmental factors as well as on chemicals, as we're going to hear from a series of what I'm sure will be a fantastic group of presentations. What is also very known, and especially for the trainees, is that at the very, very beginning, the pre-implantation period in general is characterized by an all or nothing phenomenon. So in other words, damage induced in the first few stages of human development will either have no effect through the process of compensation, or it's going to lead to a complete failure of pregnancy. But a teratogenic agent can cause malformation during the organogenesis. As I have mentioned, 2 to 8 weeks post-conception, it's one of the critical time. And what is also very interesting is that each teratogen can in particularly impact on a system that expresses maximum vulnerability on a specific window time. Heart is probably one of the most vulnerable system in the development of the cardiovascular system. In general, there are many registries, and again, I'm sure that we're going to hear about the Agency for Toxic Substances that links also different teratogens with disease, with various conditions and various disease. But in pregnancy, unfortunately, we deal with pregnancy registries. There are approximately 129 of them at this point. This is part of the CDC, where the link in between a specific medication, a specific teratogen, and a specific condition is registered. There is a lot of interest. This is news that was published just 3 days ago. Very interesting. It was linked with the brain development and the phthalates that are present in plastics seem to play an important role. I did not had an opportunity to go deep and to study the research behind the statements that these teratogens can induce irreversible brain damage during pregnancy. I'm sure that there is a lot of science and a lot of research behind this. But once again, pregnancy, and the point that I wanted to make is that pregnancy, due to the fact that we are dealing with 2 patients, both the mom as well as the fetus, it is a stage in our life that it's very vulnerable, and unfortunately, there is a tendency of being very, very cautious on the investigator side in investigating the impact of medications in particular, or as you can see in the last few months, even of vaccines and the impact that it can have on human development. So very grateful for the UIC, very grateful to the Great Lakes Center for Reproductive and Children Environmental Health. Thank you very much to Dr. Buchanan for inviting us, and very much to all our guests today, to Dr. Willie, to Dr. Vega Lopez, Dr. Loy, and of course, Dr. Buchanan, and thank you so much for the opportunity to be part of this group. To us, and of course to our residents, that they have been so happy to be part of this conference this afternoon.
Great. I'm so glad your residents are here. Thank you, Dr. Buchimski. You could stop, can you hit stop sharing? Beautiful. You already knew what to do. I was the one that was stuck. What I'd like to do now, we're really honored to have a guest from one of our funding entities, which is EPA Region 5. So EPA and the Agency for Toxic Substances and Disease Registry from the CDC fund the Pediatric Environmental Health Specialty Units. And Alan Waltz is here from Region 5 EPA in downtown Chicago. He's the director of many things that I'm going to list off, but mainly he's currently director of Tribal and Multimedia Programs Office in US EPA Region 5. And Region 5 serves people of Illinois, Indiana, Michigan, Minnesota, Ohio, and Wisconsin. So those 6 states, plus 35 federally recognized tribes. And his office manages the region's tribal, National Environmental Policy Act, environmental justice, children's health, environmental education, schools, international, smart sectors, and opportunity zones programs. So lots of programs under Alan Waltz, but we're really happy to have you. Alan, I don't know if you do have some slides to share, correct?
Yes, I do, Dr. Buchanan. Thank you so much for inviting me here today. Let me go ahead and try to share my screen here. Here we go.
Yeah, I appreciate everybody's patience with us doing the screen sharing. You know,
yeah. Are you seeing? Are you seeing? Okay, great. So all I have to do is put it into presentation mode.
Mode. If we were really sophisticated, we would have had them all, but we're not. We're a bunch of doctors, and so
can you click on display settings at the top?
Absolutely. Swap them.
Yep. Great.
Okay. Thank you. Thank you.
So
Perfect.
This is perfect. All right.
Okay. So yeah, it's really great to be here, and I do have a very large portfolio, but as you'll hear, we've tried to orient much of it around service to communities, including children's health protection. So what I'd like to use my time on today is to talk a little bit about some of the tools and resources that we have for prenatal care providers. And so let me just move through here. So we've got information on lead in paint and water, indoor air quality issues, including asthma and mold, pesticides, including in particular COVID disinfection, and this Healthy Communities team that brings together a number of those programs that Dr. Buchanan outlined to serve to help to disseminate that information, whether or not you're coming from an environmental justice or an environmental education or a children's health protection perspective. We all have that common goal of, in particular, protecting the most vulnerable of the vulnerable, which always keeps children at the center of our mission. There's outreach materials and resources for all of these programs, and the PACU will have links to all this information. I'll talk a little bit more about the availability of materials further on here. But I did want to note up front that we do have most of these materials available in other languages. If you do identify translation needs, please let us know about that. We do have resources to make sure that translations are being provided as well. In addition to the resources I outlined there, before the pandemic, we spent about 70% of our time at home, now even more. And homes do account for the major share of exposures. So that's where EPA has really tried to focus a lot of its attention. As I mentioned before, specific to our situation now, cleaning and disinfecting for COVID, there's a Healthy Homes action brochure that covers a number of the issues that I spoke about in the previous slide, as well as other factors contributing to poor indoor air quality. There's the Protect Your Family from Lead in Your Homes guide, fighting lead poisoning with a healthy diet with our partners at USDA. So there's a bunch of different resources, just let it be said, that can be really helpful to you in educating your clients and the folks that you serve, as well as having materials available for your own staff. Let's see, so you're seeing the okay, so this is where we get to the upcoming part. What slide are you seeing, Susan? I'm not sure.
Protect your chat.
Okay, great. Let me move on from that. I want to jump right to what we want to do with these materials. So these materials have been available for a while. They're available online to access and print. The PACU will, Susan will be able to share all the links with you, but we're working with Dr. Buchanan and the PACU on a pilot program we want to advance that will improve the outreach and the availability of these materials. So we're envisioning a sort of like provider toolkit or an OB box that would contain a variety of relevant handouts referenced here and other materials such as posters and multimedia materials, buttons for providers to say, ask me about prenatal lead exposure, other materials that really help to put on people's radar the fact that these resources are available for folks to take some pretty simple, straightforward measures to protect the health of themselves and their families. So if this is something that you're interested in as a kind of an amplification of what we already do, please drop your name and contact information into the chat. We'd be happy to follow up with you on that. And you see here the contact information for myself more importantly, probably the contact information for Acting Children's Health Coordinator, Elizabeth Poole, who's been working with Dr. Buchanan to advance this pilot project, and who's our main point of contact in the region for children's health concerns. So would absolutely encourage you to reach out to either one of us. And again, I really appreciate this opportunity to be with you today. I won't be able to stick around too much longer, but I think it's so great that we're able to have these meetings and to provide this kind of information to all of you. And thank you again for the work that you do every day to protect children's health.
Thank you very much, Alan. Right back at you with the children's and reproductive environmental health protection. It's really great to see you and to hear from you.
Thank you.
Let's move on to our keynote speaker, who is Dr. Blair Wiley, who comes to us from the PASU in Region 1. I explained to you that there were 10 of these EPA-funded centers around the country, and Dr. Wiley is affiliated with the one in Region 1 in Boston. She's the director of the Division of Maternal Fetal Medicine at Beth Israel Deaconess Medical Center and an associate professor of OBGYN and reproductive biology at Harvard Medical School. She also holds an appointment as a visiting scientist in the Department of Environmental and Occupational Health at the Harvard Chan School of Public Health and serves as the OB consultant to the New England region's PASU that I just mentioned. Dr. Wiley also serves on the board of directors of the Society for Maternal Fetal Medicine. In her clinical practice, she provides consultation about how environmental exposures can impact the health of the pregnancy and the developing fetus. These potential toxins include lead, mercury, pesticides, phenols, and phthalates. Her research has focused on global maternal child health with a particular interest in environmental exposures during pregnancy in international low-income settings, such as smoke from cooking fires or pesticides from subsistence farming. She has ongoing projects in Ghana, Tanzania, Ethiopia, and India. So it sounds like Dr. Wiley covers in her research and scientific endeavors a lot of the different exposures. We have asked her to come and talk to us about PFAS chemicals today, because this is an increasing exposure that we're finding all over the country, and people are asking about the effects of PFAS in their drinking water. So welcome, Dr. Wiley. We're very happy to have you.
It's great to be here. Thank you so much for inviting me, Dr. Buchanan. Before I get going, just want to make sure, can everyone see my screen? And
yes.
If, let's see if I click on this, did it advance?
It did.
Okay, excellent. So again, thank you for inviting me to speak on PFAS and pregnancy. As you heard, I sort of accidentally got into the environmental health space as a maternal fetal medicine fellow, doing my MPH, took the required intro to environmental health class and sort of fell in love with the topic, and really entered as a researcher primarily in the household air pollution cooking fire space. Had been working abroad before then. I got tagged when the PASU, which had been primarily a community of pediatricians and true card-carrying occupational environmental health experts, had to identify at least one reproductive or obstetric provider maybe 5 or 6 years ago. So it's been my true pleasure and joy to go along for the ride and actually learn a lot about translating some of this research into clinically relevant information. I want to say that I have no financial disclosures. Did the slide advance? Yeah.
Yes.
And I am really no PFAS expert, so I may be calling on others in the audience, Dr. Buchanan and Dr. Loy and others, if questions come up and I can't answer them. But I was invited as the clinician in Massachusetts to participate in the PFAS Interagency Task Force, where we're struggling with some of the issues around PFAS contamination, particularly in drinking water. And trying to come up with things. So I'm learning a lot about PFAS in the past 6 to 9 months. So I'll start with an email that came through to our Region 1 PASU, directed to me, and says, "Happy Monday, Blair. I have a pregnant patient that got a notice from her town in Massachusetts stating that the drinking water had PFAS in it and she should contact her obstetrician if she was pregnant. What do I tell her? Thanks, Emma. And so, that's often how some of these PACU consultations start. People pick up the phone, call one of the clinicians, need help. And essentially what she was asking is, what? PFAS? I've never heard of this. Some people may have seen, this in the news, but many of us still haven't even been living and talking and thinking about PFAS. So hopefully by the end of this talk, you will have more familiarity with PFAS if you don't already, understand kind of where exposure sources are coming from, think through some of the potential health effects of PFAS, particularly those identified as potential reproductive effects, strategies that you can use when you have a patient in front of you or an email like that or phone call like that, as well as resources available to healthcare providers. Think the PACU. And when I speak to OB/GYN residents here in Boston, and I ask for a show of hands, many have never even heard of the PACU. So I'm jealous of this joint PACU OB/GYN conference and might need to bring one back to our home institution here in Boston. So first, an overview of what per and polyfluorinated alkyl substances are. So this is a group of a number of chemicals, and in fact, there are now thousands of them. They were formerly called PFCs and now really known as PFAS, which stands for perfluorinated or polyfluorinated alkyl substances. And the chemistry is that they're a chain of carbon atoms that are bonded to fluorine atoms, a different variety of them. If it's all the hydrogen has been replaced, it's considered perfluorinated.
But you just muted, Blair,
Sorry, when did I get muted?
when you were just saying, describing the PFASs.
Apologies about that. Probably my finger hit the mute button. So there's a number of these different substances that are in existence. The original ones were longer chain, had fluorine replacing the hydrogen. And so as you see here on this tree, there's a variety of them, all kind of under the umbrella of PFAS. They're really quite remarkable chemicals, which is why they're in widespread use, because of that fluorine bond, are resistant to water, to oil, to lipids, fire, making them useful for us as consumers in this modern industrial world. Unfortunately, they have very long half-lives and are quite resistant to environmental degradation. And as such have entered our environment, being introduced back in as early as the 1940s and 1950s, really now being detected in our environment and in our bodies, sort of not only around the United States, but around the globe. So just some of the common uses of PFAS chemicals. They're used in non-stick cookware and bakeware. So just the original one, Teflon, PFOA, but not limited to Teflon. Anytime you have something that you're not having to do a lot of elbow grease on, think of PFAS in there. Because of those remarkable qualities, they're being used for stain resistance in carpets and fabrics, rain gear, hiking gear, camping gear. They're also found in food packaging. So when you go for takeout, that paper is sort of coated with a bit of PFAS containing substances to keep it slick. Popcorn bags, a real source of PFAS, pizza boxes, fairly widespread use. And then in aqueous fire fighting foam. So again, because the properties that make them resistant to fire, they're used and can contaminate fire practice sites, military sites from that perspective. Here's just a cartoon just showing how many different places the PFAS show up in our products in the modern world. For anyone who's interested in and reading more details about all their different uses, here's a reference for you. And I believe that my slides will be available to all who want to review them after today. So how do PFAS chemicals then enter the environment? They can enter the environment in waste or off products from manufacturing facilities of these. And that's where you'll see a lot of kind of the very highest exposures in drinking waters around manufacturing facilities. In these firefighting foam runoffs. And I once saw a picture of a town in New England using that firefighting foam at a town festival for kids to play in. And so you just begin to worry about how much exposure in a scene like that. Often, PFAS gets into the water, gets into the sewage, and that sewage sludge then is used in soil fertilizer, sort of spreading the PFAS even further. It's entering our environment from our food packaging, from our products, leaching into our landfills and sort of recycling, especially given how long the half-life is. We're exposed to it as humans primarily through ingestion of either food that has been, have chemicals coming from the packaging or from contaminated water. Because of these long half-lives, it's just sort of circulating around. So these are some more sources of kind of where we as humans are exposed to PFAS chemicals. Toddlers, for those of you who are taking care of children, they're down on their hands and knees, often touching the carpets, the furniture, the dust that may have PFAS chemicals in it. PFAS can cross the placenta. It can enter the breast milk as well. Inhalation is also a source of exposure, less so than ingestion, and probably the least is dermal exposure to these chemicals. As I mentioned before, the real challenge to these chemicals is that they last for a long time in the environment. They're hard to break down. Sunlight is not degrading them. And so these were introduced in the 1950s. And even though some of the chemicals have been phased out of production, including PFOA and PFAS, they've been replaced by a number of other PFAS chemicals, also with long half-lives. This is data from the NHANES. For those of you who are not familiar with the NHANES, it's a national survey looking at a number of exposures in the adult and children population. And you can see here that PFAS and PFOA, the levels have actually declined over the course of the last 15, 20 years as we phase them out of production. But nearly everyone in the US still has detectable levels of PFAS in their bloodstream. And as these two sort of initial historical PFAS are phased out, the other ones are sort of taking their place in our bloodstream. They are easy to absorb, but they are not metabolized well by our bodies, and therefore we don't excrete them that quickly. We often store them in the liver, in the kidneys, and then eventually slowly get rid of them. It binds to our tissue proteins, it circulates and accumulates in the blood, and can be found in other parts of human body. Like I said, they're not metabolized and therefore not excreted or eliminated quickly. Most of the excretion occurs through the urine, in females through the breast milk, and possibly during the menstrual cycle. These newer PFAS happen to have shorter carbon chains and tend to be eliminated a bit more quickly than the historical longer chain PFAS. As through that NHANES data, almost everyone in the United States has detectable levels in their bloodstream. And we will get to the human health effects in a minute, but the research from both animals and epidemiology studies suggests that there's widespread effects in a number of different organ systems. And we are realizing, and it's quickly becoming, a crisis for those who provide water around the country, is that there's detectable levels of PFAS that are above health advisories placed by the EPA. Some states even have more stringent levels of concern, leading towns and municipalities trying to figure out what to do about them. And while PFAS can be removed from drinking water, it is extraordinarily expensive. And most towns just don't have access to sufficient resources to be able to remove PFAS. With respect to this EPA advisory level, they set a level in drinking water currently at 70 parts per trillion. Individually or combined, the PFAS chemicals. And as mentioned, some states have their own advisories. I don't know where Illinois is. Massachusetts is currently at 20 parts per trillion, and specifically call out 6 PFAS chemicals. So the combination of those 6 can't exceed 20 parts per trillion in drinking water. It's also a bit of a challenge for individuals who are using private wells, which we have here in some parts of Massachusetts and New England, leading consumers to try to figure out on their own how to deal with this problem. It goes without saying that not everyone has the same exposure. And if you look at issues of environmental justice, and specifically with PFAS, as you might expect, as with other environmental toxicants, those who are in lower income households are exposed to more, are living near contaminated areas more frequently than you would expect just by the numbers. And similarly, communities and people of color, again, living more frequently to PFAS contaminated areas. So let's jump now and talk about some of the adverse health effects from PFAS. I will first start by saying, again, that this is an area of research that is exploding as we speak. It's still in its infancy, and we're trying to lift up and really understand where these wide-ranging effects are being manifest. There's a lot of media attention to this now. Even I think on PBS, they played this weekend the sort of sensational documentary, what's it called? The Devil We Know, this past weekend, which is related to contamination from the DuPont plant in West Virginia, and went through kind of some of the concerns of that community. But you're starting to see this enter the lay press, and therefore enter the minds of our patients. We talk about they're talking about forever chemicals, and they've sort of labeled these as such given their half-life and metabolism. When you think about potential health effects, there have been, from animal and human data, a wide range of potential negative health effects, from metabolism, increased risk of diabetes, hormonal changes, cancer risk, altered immune function, including a reduced risk or a reduced effect from vaccines in children's, thyroid disease, and a lot of attention and growing attention to reproductive risks during pregnancy. This is sort of the same slide, just in written out form, but these are a number of the different potential effects that have been considered as a possible negative consequence of exposure to PFAS. So often those of us, and I can't count myself as one, but the card-carrying toxicologists, environmental occupational health, often start when trying to evaluate a chemical by first studying exposure in animals at extraordinarily high doses. And there have been a number of research studies in animals and PFAS showing pretty wide-ranging effects on the liver, metabolism, suppression of immunity, impact on reproductive outcomes, including pup size, litter size, the actual birth weights, so that it begins to give a sense in multiple species that these chemicals seem to have a wide range of effects. And animal research is very important because it begins to give us clues as to which organs might be affected in humans. It can look in a sort of experimental way at a dose response level, which we can't often do in human studies with environmental chemicals. And it can be controlled, whereas often human epidemiology is pretty messy. But extrapolation to humans is not one-to-one. The way that chemicals are metabolized by animals are different. There's a lot less messiness in animals, and so it becomes hard to sort of lift up entirely. Human epidemiology studies have a lot of advantages because we're working with humans representing real-world exposures. And the actual outcomes of interest are our own health outcomes. But human environmental epi is pretty messy. There's almost never a situation where somebody's exposed to just one contaminant. And a lot of the co-exposures are correlated. It takes a long time. It's expensive to do the work well. And there's a lot of potential confounders, which make it hard to actually lift up. So I think when our patients come to us and ask, what is this chemical doing to me? I think they often are flummoxed that we can't answer that question, with as much certainty as they might expect from us. This is just another side of what's challenging about environmental epi. How do you extrapolate animal data? These exposures, for example, PFAS are ubiquitous. So who's unexposed when you're trying to do the science? The exposures seem somewhat trivial. We're talking about parts per trillion. And so sometimes that seems sort of unfathomable that could actually cause a negative effect. Which metabolites to study? That's not so much of a problem here with PFAS. The co-exposures, confounding, et cetera, and association is not always causation. I'm going to focus mostly on this one group body of work that was put out by the C8 science panel. And interestingly, what I didn't realize about this study until watching the documentary, The Devil We Know, was that this panel was part of the settlement of the community around the DuPont plant in West Virginia. They brought a lawsuit against the company about contamination in their drinking water. And instead of taking the money individually, had the settlement go to the creation of this panel, which hired 3 epidemiologists to not only review literature that had been previously published, but study health effects in their own community to be able to try to answer that question: what are these PFAS chemicals doing to us? So this study, the C8 study, funded by this settlement, occurred in the 2000s. They had participation by more than almost 70,000 individuals. And they looked at a number of different health effects. And they concluded that for at least these 6 health outcomes, that there was probable link between exposure to PFOA or PFAS and increased cholesterol, ulcerative colitis, thyroid disorders, kidney and testicular cancer, and then for those of us as obstetricians, this increased risk of hypertensive disorders of pregnancy or preeclampsia. It doesn't mean that the other health effects that they studied were not linked, or we won't find in the future enough evidence to find a probable link. But in what they could tell from what was available and from their work on in this population, these were the 6 that had the most evidence behind them. So in terms of thyroid, they found, particularly in women, even more than the men, with increasing cumulative PFOA exposure, that you saw an increased risk for hypothyroidism and hyperthyroidism. They saw elevated cholesterol in these communities with high levels of PFOA and PFAS in the drinking water. even more so from occupational exposure, those who were working in factories. They found an increased signal for these two types of cancers, which led the IARC to classify PFOA and PFAS as a possible carcinogen. And then for us in the OB world, they were able to pull out that there seemed to be a link with preeclampsia and hypertensive disorders of pregnancy. And this was not only from work that they had done with this population, but a review, as I said, of other literature that had been published. And because they were able to see this association kind of in several different groups of pregnant individuals using different exposure indicators and slightly different ways of measuring preeclampsia, and still kept getting a modest effect size, they felt that this kind of consistency of the results made it probable. And the better the exposure measurements were, the stronger the effect size. And so this was their conclusion. Just going to highlight the work that they did themselves. They, of the community of 70,000, they had about 10,000 who had reported pregnancies and were able to do some pretty elegant estimation of PFOA levels using measurements and then extrapolating back to the time of the pregnancy based on how much effluent was coming out of the factory, where they lived, and all sorts of things to get a better estimate there. And you can see that these effect sizes, there was a dose response. So with increasing quintile of exposure, the risk for preeclampsia was increased. Now, you know, we may not think that 1.2 or 1.4 even is a huge effect size. However, when you're applying this to entire populations, that increases the risk of and the numbers that we would be seeing as obstetricians. In terms of reproductive outcomes, they did not find a link with birth defects, miscarriage, stillbirth, preterm birth, low birth weight. However, some studies do suggest that, and I think that we have a lot left to learn. I think it's important to recognize that especially in environmental epi, no single study, whether it's animal or human, can really establish causality. And we really need to see repeated studies, consistency, slightly different exposure and outcome, all giving the same message before we can say, yes, this is what is happening. Just to give you a sense of how this field is exploding, there's something called the PFAS Tox database where you can go to and they quantify a number of different health outcomes. And these numbers represent the number of studies. Green is human, I think blue is animal, and then you can hover over them and they'll give you a list of the references. So for us as obstetricians, there's a whole reproductive system column. So for those who want to dig deep, there's a lot of work being done and a lot of work coming out. And I think we are just beginning to hear about it. This is the number of different systems that they enumerate the studies as they come out in real time. And just to, why should we care as obstetricians in particular? Dr. Bohemsky spoke to this at the beginning. Fetuses are particularly vulnerable. They are not little adults. Their exposures are greater per body weight. Their metabolic pathways are immature. They're undergoing rapid development. Their epigenome is sort of being established and reestablished at critical time points in their development, both during pregnancy and right afterwards, which make them particularly susceptible. Also, just a quick aside, we can find PFAS in breast milk. And so some exposures may continue not only prenatally, but postnatally as well. So a lot of, kind of high level talk there, not reviewing those studies in great detail, but I think that we can say with pretty clear certainty that there's a link with preeclampsia, and probably I suspect we'll be seeing other outcomes join that list as we move forward in time. Let's go back to that email. So what am I to tell Emma, or if this person was sitting in my office, what should I tell them? And I think that all of us, even if you hadn't heard about PFAS, before today, this may come up. And in fact, when Dr. Buchanan suggested I include the number of sites contaminated in the US as part of the title, by the time we had initially put it on there, and now there's been, I think, 300 or 400 more sites that joined the list. So we went up from 2337 to 28 something or another. And so you can see where you guys are. You're in a world of blue as well as I am in Massachusetts. In kind of general talking points about environmental health, I think we as physicians want to feel like we know things. And when we get asked a question we don't know the answer to, sometimes it can unglue us and lead to sort of unsatisfactory patient-physician moments. And so I think that it is important when people come to us with concerns about things that are a little bit outside of our knowledge base, or even where the science is not clear yet, trying to have that interaction be a positive one, understanding the concerns. And I feel like I learned from people like Dr. Wolf here in Boston, just listening to how he talks to patients, elicits their concerns, even when there isn't an answer. So I'm trying to get better about that, being honest about what I know and don't know, and not sort of hiding behind, oh, if we don't know it, it's not a legitimate concern. I think what I realize is one can always ask for help. And when it comes to environmental health concerns, the PACU is a great place to go, because not only do you have access to pediatricians, environmental health, occupational health experts that can actually help you sort of formulate how you think about the questions. They often have a little fact sheet to go with it. And if it is a question that is a bit more confusing, we'll tap into this whole national network and ask for help. So speaking of fact sheets, I often find handing something to a patient is helpful, and lo and behold, there are already a couple of PFAS fact sheets specific to pregnancy. Here's one that comes out of the UCSF PERCH program, endorsed by FIGO and others as well. We have a PFAS fact sheet in Region 1 PACU. It's not specific to pregnancy. I suspect you all have one as well, but it's often a good starting point for giving patients information. General recommendations around management of individuals exposed to PFAS, not pregnancy specific, is that there's not a lot of evidence for us to be doing things different than the established standards of care. So even though that there's a link with hypercholesterolemia, the clinician recommendations are just to follow the standards of care, do the cholesterol screening as you should, no change to the immunization schedule. And that can sometimes leave patients, particularly if they get a letter from their town that their water is contaminated, feeling a little bit left out by the clinicians. Similarly, for pregnant, breastfeeding people, our whole sort of antenatal care is designed around the detection of preeclampsia. And so there's not a ton that's being recommended differently for someone who's PFAS exposed. I suppose in our current COVID days where we're doing some things virtually, it's important to make sure that people have a blood pressure cuff if you're not seeing them in the office. Cholesterol screening in general is not regularly performed just because cholesterol can go up during pregnancy. It's not unreasonable to send a TSH. I think we send it sort of for a variety of reasons, almost universally, but not quite. But really not a whole lot of deviation from the standard of prenatal care. We also don't recommend, discontinuing breastfeeding because of PFAS exposure. You may have some patients who ask for their blood to be tested and a level to be measured, or come to you with a level that was tested as some part of their community. And it's really hard for us clinicians because there's no correlation with that level and a risk, or what does that predict, like we do with lead. So there's a whole algorithm. If your lead is at this level, then we do that. If it's at this level, we do that. There is no similar sort of algorithm for PFAS at this point. And so while someone may be interested in this, it can be a bit confusing. Sometimes I've learned from, some of the folks and advocates for knowing is that, sometimes just getting the blood tested is therapeutic to the patient. And so I've seen, some of our PACU clinicians order things even when we don't know what the answers may mean. But couching sort of what that means ahead of time, I think, is important. This is, there was the Peace site in New Hampshire where the community was getting tested. So they're coming in with these sort of report outs, leaving a lot of clinicians sort of confused about what to do. You can talk about reducing exposures to PFAS as you can with any environmental toxicant. However, I think it's important to acknowledge that those with long half-lives are harder to change by the individual, especially quickly. But if you get a letter from your town, you can use alternative water sources, bottled water for food preparation. There are filtration systems that you can purchase as an individual or household to reduce exposures to things like PFAS. They can be expensive. For those who are eating local fish, sometimes bodies of water are contaminated. And you can reduce your exposures to consumer products with PFAS. This is a Clean Water Action Group. And so for individuals, they recommend getting rid of your nonstick cookware. If you can't, reducing the heat at least, popping your own corn, not using the popcorn bags, bringing, I like this one, bringing glass containers for to-go food, trying to look up for the dental floss that's not PFAS containing, asking or looking for products that are not coated with stain resistant materials, and just being more consumer advocates and demanding products on the market. And I do think that there's power in the voice of the consumer. I found this study kind of interesting, which shows that there are behaviors that on average can impact kind of what your PFAS or levels in your bloodstream are. So these are bean plots. If you've not seen them, they're sort of like exposure clouds. The black line is sort of the median exposure there. People who dust a lot have lower PFAS exposures than those who don't dust with regularity. Similarly, if you vacuum a lot, your PFAS levels are lower. If you are a high microwave popcorn intaker, your level is higher. Or if you have a water filtration, that there may be some differences there. But I think that it's really important to acknowledge that the individual here probably has less agency than we do as a community of scientists advocating for policies to change sort of the ability of these contaminants on the marketplace. So I think my time is coming to an end. So a few takeaways. Most people in our country and actually the globe now, thanks to our introduction of these chemicals to the world, have PFAS in their bodies. And there may be folks coming to us concerned about their exposures, and we need to be able to talk to them, or at least say, you know what, let me find and phone an expert and get you some information that you're looking for. You can reduce your exposure, but it's going to take some time. It's not an overnight change by these measures we've been talking about. And as clinicians, there's not a whole lot for us to do like there might be in the lead world, but it's reasonable to talk through what the patient might be asking for, and occasionally thinking through with them whether sending some blood for either the outcome or the exposure level might help them. And I'll end with where I think, especially for these persistent pollutants that we really need to be arguing for as scientists and clinicians, is really anything that's long acting or long lived in the environment really probably shouldn't be there. By the time we figure out what it does to us, to the animals, to the earth, it's sort of too late. And given how messy and challenging the epi is, it will be too late. So I think advocating for that is probably a good starting point. And as clinicians, I think, we have a power in our voice that maybe we aren't using as much as we can. I know that the pediatricians are many sort of decades ahead of us in the OB world in terms of environmental health, but I think we're catching up to really make a difference and advocate for clean water, these basic things for the protection of our patients. And for those of us who are practicing obstetricians, we have very few things that can change or prevent some of the common pregnancy complications like preeclampsia, preterm birth. It feels like every time we find one, 5 years later, the story is that it doesn't work. And so maybe if we really want to reduce preeclampsia, we're going to have to think at the policy, the sort of high level instead of the individual level. And with that, I will stop there, and happy to field questions by email. Again, I am no PFAS expert, but I really have enjoyed my time on the Massachusetts Task Force and being asked to pull this together for this audience. Thank you so much.
Thank you very much. I'm so sorry you don't have a whole auditorium of people clapping for you. Just imagine everybody clapping. Blair, it cracked me up when you keep saying you don't know a lot about this, because I'm not sure anybody does, particularly clinicians.
Right.
It's such, you said it's the research is just exploding, and it's true. And not only is the research exploding, but they're finding PFAS. It seems like every time they check the drinking water, they're finding it. And that is also exploding. The magnitude is just overwhelming. And one of the reasons I think you actually know more than most other clinicians is you guys did have kind of an outbreak up there, and the public health departments were telling people to get tested.
Yes.
Yeah. So you kind of had to scramble and come up with some answers, and we haven't had that yet. I mean,
yeah. And our state government, state legislators are very interested in this, and they're trying to do right by the state and figure out what should they be saying. Should we be banning popcorn bags, or should we be focused on cleaning up the water and trying to find resources for that? They're talking less about what clinicians should do, but it's been fascinating to just hear from the wastewater managers about how complicated and expensive it is to get it out of our drinking water.
Yeah, I mean, what a mess. And I imagine that that's going to come to our other communities, because from your map, you can see how it's spread around our region as well. And I know that ATSDR is dealing with some outbreaks. And as I was looking at the attendees, I did want to introduce, we have two guests from the Agency for Toxic Substances and Disease Registry, the branch of the CDC that deals with community level exposures, Mark Johnson and Motria Caudle. I don't know if Mark or Motria, Mike, if you could unmute them, and either one of you could mention or talk a little bit about what is going on in Region 5 with PFAS. Our PACU is not getting a ton of calls. We were getting a few from Michigan. I did have a call from somebody who wanted to know about breastfeeding and PFAS levels. This issue of screening is, sorry, Mark, while Mike is unmuting you, let me mention this, that this issue of measuring levels is really tough. The National PACU Network is not promoting it because, as Dr. Wiley said, there aren't any known health cutoffs. We just don't know enough yet that above this level is okay, is bad, and below this level is okay. But patients, it's reasonable if you get a letter saying your water's contaminated that you want to know how much is in your body. So I'm not actually sure what I'm going to do once it hits us. So anyway, Mark, I didn't know if you wanted to weigh in here.
Yeah, thanks. This is Mark Johnson. I'm the Regional Director for HSTR Region 5 of the Chicago office. Thanks for the introduction, Susan, and thanks, Dr. Wiley, for your presentation. It's really informative and I think a really good overview of the issues, especially from a clinical perspective, and some of the challenges that physicians face in answering questions from their patients and trying to interpret a very complex field of research. So in terms of Region 5 that we're supporting, we have one project that we're particularly funding. It's called the multi-site health assessment for PFAS, and that's focused in Michigan in two communities. One is in the Rockford, Michigan area where the Wolverine Worldwide tannery has been the source of PFAS in terms of its disposal of contaminated materials in landfills and applied sludge application areas. That's receiving a lot of attention, both with regards to sampling of private wells whose well water has been impacted by the contamination, as well as testing of residents for blood testing. And the second one is in Parchment, Michigan, just north of Kalamazoo, where a paper mill was the source of PFAS used in food grade packaging and has impacted the municipal water supply for that community. So the Michigan Department of Health and Human Services is working with our funding and state funds to look at the health impacts in those two communities to assess both in terms of identifying people who've been exposed, but also then to find mitigation for that. Now, the state of Michigan is probably far ahead of any other state in our region because they're doing a statewide assessment of all municipal water supplies for PFAS. It has resulted in a identification of a fairly large number of communities where PFAS has affected municipal water supplies. And so they have a very aggressive approach in looking at that. Also, I see Emily Hansen from Minnesota Department of Health, where much of this research first started with regards to the 3M facility. And they've really been leading much of this work in identifying methods for assessing exposure and water testing procedures and identifying mitigation processes. So I think Region 5, in addition to the C8 study that was done in West Virginia and Ohio that Dr. Wiley mentioned, we're really sort of the source of a lot of the research that has come out from PFAS investigation. So we look forward to being a resource to clinicians in our region and working with Susan's group to provide that kind of support.
Thanks, Mark. That's really helpful. I wanted to bring it back into the exam room and say two things. One is that if clinicians do receive questions from patients, and Dr. Wiley mentioned what I've experienced myself, that feeling when a patient asks you something that you don't know the answer to and how you want to just kind of maybe blow it off or ignore that question. We are specifically funded to answer questions like that. So we have a hotline. You can call any of the 10 PACEs around the country. You can call us and we can communicate either with you and give you information, or we can communicate with the patient. Because I know that some of these questions are hard and I'm not even sure what I would say for some of these screening questions. Are there any other, we do have one question in the chat about how are the potential effects of PFAS being communicated to lower income households? Blair, I don't know if with your outbreak up there, if your departments of health made any special effort to, since they may be more highly exposed, the slide that you showed, is it being addressed, the communication to them being addressed?
There was a joint effort between the PACU and the Department of Environmental Protection as they went to a couple of these contaminated sites where, a letter was going to come from the town offering, if you want to be tested, you can come and the community will do it. with a few bullet points of what is PFAS, where, why is it contaminated in this site, that kind of thing. That Alan and the team sort of went back and forth on trying to help provide that. But I think that that's part of the challenge is people might get a letter like this and have start Googling what is PFAS, right? And so knowing for people to go to the right spots, and I think that the fact sheets that the PACU puts out are great, but sometimes they're pretty dense and need to be simplified a bit too.
Yeah. And in terms of drawing blood, so,
oh yeah,
I mean, I may be revealing my bias, but I am kind of going over to let's draw levels. If they're getting exposed and they want to compare their level to the national average in order to raise hell.
Yeah.
And then
I'm making that evolution myself. And I find it actually therapeutic in that even when there's uncertainty, and I think as MFMs and obstetricians, we are quite comfortable with a fair amount of uncertainty, maybe more than the average clinician. But I think that people, they want a takeaway. And as long as you tell them what we know and what we don't know, I don't think it's unreasonable to give that to them. And I think that their voice will be powerful as consumers and maybe get us a lot farther faster than we as, the cautious epidemiologists will. And so sometimes the advocacy can be ahead of the science, and I think that's okay. I need to look up, there are commercial labs that will run the actual blood levels, but not all commercial labs. And I feel like there's one in Georgia, but I could be making it up. So you have to, if you're going to send them, you can't just like write it on your hospital order form. It would be a send out and would take a little bit of time, but that's something we can figure out from the PACU and get that information back to you.
Well, that adds to the complexity too, because there are thousands of these chemicals.
Right.
And the panels aren't going to test for all of them. So we really are still in a lot of gray area in this arena. And one of the points of having, of us talking about this is to raise the awareness among clinicians. Nevertheless, there's a lot that's unknown. Patients are going to come asking about it. So we are just about time. I really want to thank you, Dr. Wiley. It was very informative. I'm so happy that you were able to join us. You didn't have to travel to Chicago.
Although I would love to travel to Chicago, but
I know,
it's
a nice excuse. We'd love to have you. We do have a schedule for a 5-minute bio break. So let's take a 5-minute bio break. And when we come back, we're going to have 3 shorter presentations on bisphenol A in the placenta, about lead in pregnancy, and using an exposure screening form in the exam room with your patients. So see everybody in 5 minutes. Thank you very much, Blair. Okay. My screen looks a little odd with the little square with the B in the middle.
That looks like, I can see the presentation.
You can see the presentation?
Oh,
Yeah.
switch it back. It's on speaker view now. There we go. Perfect.
Okay, great.
Is it on speaker view now?
No, now it's just in PowerPoint. If you could restart the slideshow.
Okay, here we go. Are
Oh,
we good?
and then swap your display.
Okay, here we go.
Perfect.
All right, thank you.
Wonderful. So welcome back, everybody. Let's start our second half with our 3 short talks. The first one is by Dr. Almudena Vega Lopez from UIC. She's an associate professor in the Department of Pathology at UIC, and she leads a research program on developmental toxicology. Her NIH funded work focuses on the effects of obesogenic chemicals and bisphenol analogs, with particular emphasis on placental and ovarian function. Her work includes in vivo and in vitro studies of toxicity, toxicokinetics, and endocrine disruption. Dr. Vega Lopez is author or co-author of 80 peer-reviewed publications and serves on the editorial board of Toxicological Sciences. And I'm really happy to have Dr. Lopez with us today because we're at the same university and we haven't met before. And I didn't know she was doing all this cool work on bisphenol S and the placenta. So I'm really looking forward to your talk, Dr. Vega Lopez.
Thank you, Susan. And I just want to make sure that my slides are moving. Okay, cool. So thank you, Dr. Buchanan, for inviting me, and I'm thrilled to be here today in this reproductive and environmental health conference. So some of the learning objectives of my talk overlap with those of Dr. Wiley, but today I will be focusing on bisphenols, which have a much shorter life to that of perfluorinated chemicals of the talk we've heard earlier. So I want to bring everyone's attention to the fact that we can find chemicals in a plethora of different consumer products, from personal care products to food, but also in other products that we're not as aware of, such as pesticides or resins or binding fluorine. And I also want to bring your attention to the fact that chemical exposures don't stop during a very vulnerable period, which is pregnancy. And these chemical exposures don't occur in isolation. And this graph, although is a decade old, it really illustrates the fact that we're exposed simultaneously to, in this case, and each one of these bars is a different woman, to over 25 to 45 different chemicals at the same time. So this gives you an idea of the complexity of this field and trying to understand what the effects of these exposures are all about. So in my lab, we're interested in chemical exposures during pregnancy because many of these chemicals can cross the placenta barrier and affect the developing fetus. And many of these chemicals as well are endocrine disrupting chemicals, meaning that they can interfere with the endocrine system. And one of these organs belonging to the endocrine system is the placenta. So focusing on bisphenols, my lab started studying bisphenol A. Many of you, it's also known as BPA. Many of you would have heard of this because now you can find in the supermarket BPA-free bottles. And these all started because of the health concerns that the presence of BPA could lead to reproductive dysfunction, metabolic dysfunction in after exposure during pregnancy. So now they're banned in baby bottles, but there are many other consumer products such as lining of food cans or paper receipts where BPA is still present. Now, more concerning is that the manufacturing industry, knowing the push for the consumers to not wanting to use BPA products with BPA, has shifted to the use of other chemicals such as bisphenol S as part of the manufacturing process. So the placenta, to this group, I doubt I have to introduce what it is, but it's an extremely vulnerable endocrine organ. And what I wanted to point out to you is that BPS has been increasingly detected in pregnant women just over the past 6 years, from 40 or 60% to now over 90%. So with this introduction, or what we knew at the time, we had two open questions in my lab, two that we wanted to address. One is, if a mother is exposed to bisphenol S, does it bathe the placental bed and transfer into the fetus? And two, if the placenta sees or is exposed to BPS, can it be affected and its function be impaired? So in my lab, we use sheep as an animal model for human pregnancy. And the reason is that sheep, as well as humans, are monoovulatory, so they bear 1 or 2 fetuses in any given pregnancy. They're both precocial species, so their developmental organ maturation occurs and is almost completed prior to birth. And they're a fantastic animal model sheep to do in vivo monitoring during pregnancy, and I'll tell you about that in a sec. Now, given there are certain differences in the type of placentas between humans and sheep, there's really no good placenta animal model unless you go to apes in terms of recreating hemoporial placentas. But just for the purpose of this talk, blood of the mother and the fetus never cross in neither species. And we have a few additional levels or barriers separating these two blood compartments between species. So to address the first question, we did a toxicokinetic study using pregnant sheep. And at day 115 of pregnancy, as you can see, it would be unethical to do what I'm going to explain in humans, and therefore that's where we use animal models. So at past mid-pregnancy, we did a fetal catheterization surgery that allows for real-time monitoring of fetal content or chemical content in their blood. So it's a pretty involved surgery that involves laparotomy, exteriorization of the uterine horn, exteriorization of the fetal limb, catheterization of the fetal cranial tibial vein. We're able to catheterize vein, artery, as well as amniotic fluid. And then you would suture back fetal membranes in the uterus. And then through a side pouch, you're able to real-time collect samples from the living fetus. So after a week of recovery of this intense surgery, we're able to do a kinetic study over 3 days. And in this case, we use a single dose of either bisphenol A or bisphenol S at 0.5 milligrams per kilogram. And we're able then to sample maternal as well as fetal blood. So just to give you an idea of how this mother after recovery looks like when she's being collected, when her fetus is getting the blood drawn, she's really more interested in what I have to do with the camera than what my grad student Jeremy was doing on her side. These animals are housed together to avoid stress, because the one thing that stresses sheep the most is isolation. And the type of data we can get is as follows. So these 2 panels represent levels of bisphenol A in the mother. We take this through jugular vein sampling, and you can see that after 36 hours, you can no longer detect these chemicals in her blood. And you can really see how short of a half-life these both chemicals have. Is around, for BPA is around 6 hours. So the picture on the fetal compartment is very, very different. You can see that already for bisphenol A, at 3 days or 72 hours after, the fetus has not been able to clear fully the amount of BPA that had been transferred. And similarly, it was very similar for BPS. Now the difference, the key difference is that you can see that for BPA, the half-life is about 2 days. So it takes 2 days to go from this point to half of that amount about here. Now for BPS, the calculated half-life, you can see it's a much flatter line, is about 16 days. So it speaks to how much of a chronic exposure a fetus that has been exposed to BPS could have versus BPA. Now there is a lot of, I'm not going to go into this. I could talk about this for probably a day in terms of the magnitude of difference in the maternal as well as in the fetal compartment, but that has to do with solubility and the exposure route we gave. So we can use these data to really get at risk exposure predictions, doing mathematical modelings and doing physiologically based toxicokinetic models. And when you try to do this in a pregnancy model, in a pregnancy context, it gets really complicated because you have to model, of course, a few organs that are highly vascularized or that can keep the chemical for a long time, like fat. But then you have to add the placenta to the model. Then you have to add the fetal compartment to the model and the kinetics between the fetus and the placenta. And this is just for the unconjugated form. This is the free form of the chemical, which is the active one. That is key in this field. But once the chemical goes into the liver, it actually opens a whole side of another type of chemical, if you will. The liver conjugates this chemical. It makes it larger, but it also easier for the body to excrete it out. So using this modeling, what we did using our kinetic data as well as others, we predicted. We tried to do a simulation of 15 days. Every day we would give 1 dose of the EPA reference dose for BPA. And this blue over here represents the total and the conjugated. And very minimally here, you can see the free form of the conjugated, which is really tiny because our bodies are really effective at conjugating. Our livers are amazing organs. But what we can see here when we blow this panel up is that for BPA, you can see how every day you would get the dose and it peaks and it clears. But the picture for BPS is dramatically different. When you blow this, the free form, you can see that because the half-life was so long, it's because the clearance is much less. And you can see how it increases over time. So this actually speaks to the need to study. Each chemical is very different from each other. The kinetics are different, and the how our bodies respond to chronic exposures is dramatically different. So the second question was, now that we know that this chemical can actually bathe the placenta and cross into the fetus, and we've done many studies using these chemicals on fetal development, but I won't go into that today. We ask the question about what happens to the placenta. So again, we continue using sheep as an animal model. And in our study, we use 0.5 milligram per kilogram per day. Like Dr. Wiley was explaining, animal models often use higher doses of exposure. Now, when we did this study, and I'll go to that in a second, when we did this study, what the amount of BPA that we could find after giving this to the mother was 2.6 nanogram per ml of unconjugated BPA, which is in the range that we can find in umbilical cord in humans. So we exposed animals, females, to either BPA or BPS during mid-pregnancy to this dose. And we allowed then for a 20-day washout period. And after that, we collected placentas from these animals, and also blood samples every 2 weeks. So just as a curiosity, the sheep placenta is a cotyledonary one. You can, it's scattered with mini placentas, if you will. You can find 80 or 100 of these scattered around the fetal membranes. And when we started looking at what happened to placentas that had been exposed to either BPA or BPS, we found that grossly, we didn't see difference in placenta weight or significant differences or placentum count, no histopathological changes that were overtly different, inflammation, etc. Tissue contributions of the different compartments or the intervillous space. But then we started looking into the placenta endocrine function. And the placenta secretes progesterone as well as glycoproteins. So glycoproteins are HCG for humans, and pregnancy-associated glycoproteins, or PAG for short, in sheep. And what we found is that we started to remember the exposure at day 30 of pregnancy, and we continued till day 100. So during the exposure window, the levels of PAGs, these glycoproteins, were significantly reduced. You could see that the effect is starting at 2 weeks, but then once we remove the exposure, you can see that there is somewhat of a recovery. Now, where are PAGs coming from? They're coming from a trophoblast layer. So these cells are binucleate cells. These are the analogs to the syncytial trophoblast in the human placenta, this multinucleated syncytia that produces HCG and progesterone. So we then asked the question, okay, how about these cells? We can actually label them by immunohistochemistry in the lab. And we found that even after those 20 days of washout period, remember there was a recovery, we can see that there's a 20% reduction in binucleate cells. Now these cells are binucleate. They form through a process called fusion. These trophoblast cells can form either multinucleated syncytia or binucleate cells in the sheep. And that occurs through a chain of events. First, the cells overexpress a protein called icadierin. They get together, they overexpress gap junctions, they start communicating to each other. And then through a cyclic AMP process, they kick in glial cell missing factor 1. This is a transcription factor that says, let's fuse. So then a number of profusogenic genes, that one of them encodes for syncytin, which is a protein that it's required for a formation of multinucleated syncytin, it's upregulated. So we asked the question, what happens in a BPS exposed placenta in terms of icadierin, these profusogenic genes, and this transcription factor? So BPS actually reduced by over 50% the expression of icadierin. It also reduced the expression of these two profusogenic genes, and I'm just showing you a couple of examples, but surprisingly upregulated this transcription factor that controls these two genes. So our working model for this for this part was that, like I said, in physiological conditions, if you have icadierin overexpressed, your cells will actually fuse and form binucleate cells, which actually secrete normally PAGs, right? Now, in the context of BPS, we found there's a reduction in icadierin, reduction in profusogenic genes, and we think is a compensatory mechanism to try to keep this at least working somewhat by upregulating GCN1, and that leads to reduced trophoblast fusion and endocrine dysfunction in the placenta. Now, so far, everything I've told you has been in sheep. And the question is, so what? Is there a human translation to these findings, right? Well, so we've actually followed up on our animal model work. And before I go there, I need to dive deep into the structure of the placenta. So we have our fetus, our umbilical cord, we have the placenta, and if this cord over here is this panel to the right, this is the chorionic villi. The chorionic villi help attach into the maternal decidua, and this inner layer that has the light blue is layered with cytotrophoblasts. So these are cells that at the anchoring villi, at their tips, they did differentiate into what we know as extravillous extravillous trophoblasts. They help attach the placenta, remodel the spiral arteries, right? And then outside of that layer, we have the syncytial trophoblasts, which is this darker blue, which is what I've been telling you. It was the analogous layer to the binucleate cells in the sheep placenta. So there are two processes that are key in placenta function, other than stereogenesis and so many others. One is cell invasion by these EVTs, and the other one is cell fusion to form this syncytia. Now, these two functions are regulated, at least partially, by EGF, epidermal growth factor. Now, EGFR is extremely abundant in the placenta. And just to illustrate how abundant it is, you can see that these are all the organs. This is protein atlas data, like how much of this EGFR is expressed in every tissue. You can see placenta is leading. So it's an extremely important factor. And like I alluded to earlier, placenta function is partially controlled by EGF. We can actually model this in vitro. We can take cytotrophoblasts from a term placenta, we can give EGF, and we can induce the formation of syncytia. This is, again, in vitro, it doesn't look like a layer of syncytia, but this is the best that we can do in vitro. So we asked the question whether BPS impairs this process of fusion, that we hypothesized it was impaired in the sheep study. So we took term placentas, uncomplicated singleton C-sections. We can get cytotrophoblasts. We can isolate them by Perkel gradient. And Elvis Ticiani, a very talented postdoc in my lab, asked this question. And you can see that even if you put control cytotrophoblasts after 96 hours in vitro, you can achieve some spontaneous cell fusion. When you add EGF, you can almost double that. If you add BPS, nothing happens. But what was very interesting to see is that BPS, and the dose is 200 nanograms, so we're orders of magnitude higher to what the fetus is seeing, but this is the upper limit of exposures in humans. So we're still within environmentally relevant doses. So what happens with BPS is that it fully blunts the EGF mediated fusion in the human placenta. We dive into the mechanism. So this is EGFR. And I'm gonna try to go fast through this, but I'll be happy to answer any questions later. So we dive into EGFR and how it's modulated by BPS. So the first thing is, does BPA compete for EGFR? Can it bind? And when we did a binding assay, we can see that it really is, there's a dose-dependent effect on binding. And this is the positive control cetuximab, which is an EGFR antagonist. We also, we then dive into the activation. So when we have, when we give EGF to this cytotrophoblasts, you see an upregulation or an increase in phosphorylation, excuse me, for EGFR. Now, when you add BPS to the combination, you partially reduce this effect. And the last thing that I'll mention today is this receptor needs to be internalized once it gets activated. So we tested that in vitro. And it's a bit complicated technique to go through, but this is our negative control. So the labeled EGF, this is a positive control that competes for the labeled EGF. And then you can see that there is a dose-dependent reduction in EGF internalization when BPS is present. So we kind of ticked the 3 boxes. BPS reduces binding, interferes with binding, diminishes activation through phosphorylation, and also diminishes internalization. So the last thing I'll tell you today is that we're doing some modeling to try to understand how BPS is able to hijack the EGFR receptor. And over here, this is the EGFR receptor, and this is BPS. And doing some simulation modeling, we found that there are 5 sites where BPS can get into EGFR. And we're doing mutagenesis studies, and we found that 2 of these sites are key to eliciting the function I've just talked to you about. So to conclude, I want to kind of recap my really fast talk to say that we have demonstrated that bisphenol S, this emerging chemical, crosses the placenta barrier. It accumulates in the fetal compartment to a larger extent to that of BPA, and that both the ovine as well as the human placenta are susceptible to BPS. And we think the EGFR receptor is the mechanism by which that happens. Now, remember that this is an extremely complex picture, and this is very simplistic. We can only do one thing at a time, but this is a simple 1 chemical, 1 effect. This is what we have to deal with. So I want to just spend a minute thanking the people in my lab that did this work, highlighting Jeremy Gingrich, which was a former grad student currently at the FDA, and Dr. Elvis Ticiani and Dr. Yongpu that led the work on the human placenta that I just mentioned, and of course my funding sources and my collaborators. And with that, I'll stop.
Yes, thank you. Thank you. Here's your applause. I'm sorry, Kim, but it's funny you were saying it's simplistic, but it was really a much more micro complex level that I'm used to seeing. But it's fascinating to me how the epi, which is what I'm used to following, really echoes what's happening on the cellular level with the endocrine disruption. And it's certainly on the epi level, we see BPA and now BPS having a definitive association with endocrine disruption. So thank you very much. I was really happy to hear that remarkable talk. But I'm going to move on to Dr. Gary Loy in the essence of time, because Dr. Loy is going to talk to us about environmental exposure screening. And he is a maternal fetal medicine specialist as well. He's a visiting clinical professor of OBGYN at UIC College of Medicine in Urbana, our new medical school, and faculty at the University of Chicago here in Chicago. His clinical academic work has included development of expertise in diagnosis and management of fetal growth restriction, preterm labor, and pregnancies with fetal anomaly. His role within our PASU has included College of Medicine course development and teaching, and public speaking advocacy pertaining to health effects of climate change and airborne particulates, including in the University of Illinois Urban Medicine program. He was also co-director of that urban medicine program, and we did some lectures together then. He's past chair of the Chicago Department of Health Maternal Advisory Committee and served on the Illinois State Maternal Mortality Review Committee. So thanks for joining us, Gary.
Thanks. Is everybody hearing me?
Yep, I can hear you.
Good. I want to join that lab. That looks like a lot of fun.
Yeah, absolutely.
So today, I come to you as a workaday doc that's seeing patients in the office, seeing patients in ultrasound. And I've worked most of my life in underserved communities. So I'll talk to you today about the importance of the intersection of social determinants of health and our environmental screening. It's a pretty simple concept, but maybe if we talk about it for 20 minutes or so, you'll appreciate that intersection even more. The objectives here would be to justify implementation of the environmental exposure questionnaire on the basis of how it impacts clinical care, propose a plan to use this exposure form, which is in your packet of information, by the way, use that exposure form in your office and think about what kind of questions you need to create to follow up some of the positive answers that you get during this environmental screening effort. I don't have any financial disclosures to claim today, unfortunately. So why do we advocate for environmental exposure screening? If you want to learn about the health of a population, look at the air they breathe, the water they drink, and the places where they live, which Hippocrates said a while ago. But how successful have we, you and I, been in advocating for this process of environmental exposure questioning? Has it been incorporated in your own experience in your office? Is there a part in your EMR? Yeah, and even if you've been solved this environmental screening issue, I hope that some of the things we let you think about during this 20 minutes will reinforce its continuation. And this discussion should support our efforts and advocacy to screen for environmental exposures, because it can really add value to your patient encounter. In the office, we have many things that we need to do during a prenatal or a preconceptional counseling visit. Now, we see a lot of patients in prenatal care, but you don't have to do environmental screening every time. You just want to incorporate it into one of your visits. So we really want to screen for these environmental exposures. And remember, we're still screening at all times for social determinants that impact on our care of the patient. Even Epic has it hardwired, right? And they have a social determinant or context of care area in Epic that we or somebody has to address during a visit. And you'll see some of these categories come up again and again on those aspects of a patient's life that intersect with some of their environmental exposures and, of course, our subsequent care given to the patient. This is one diagram that I like about what happens when there's a social group that is somehow discriminated against and resulting in residential segregation. We've already talked about that, in that some populations live in areas that have more environmental exposures, as we all realize. But just to think about how this all fits together, the resident location matters both in terms of structural factors, which we've talked about in the environment, which are the environmental pollutants and hazards, develops a community stress, causes exposure, and then there's an individual level of exposure that really we're trying to get at in the office, and that is, what kind of dose are we talking about? Which brings up to, do you think that we're going to have, Dr. Wiley, we're going to have to go up on that parts per trillion in what's okay in the drinking water?
Or down, you mean?
Yeah.
Yeah, absolutely.
It seemed like it's certainly having a bigger effect than I would expect in a part per trillion, even if it's 70 or however that works. So there are individual exposures, individual stressors, and these result in an effective dose, and there are health effect disparities. Now, Saul Wiener, who's one of your U of I faculty, was a dean, and I worked with him closely a while ago, has put together 10 categories that have to do with social experiences, social condition, and he calls them contextual categories. They're really social determinants of health: cognitive abilities, emotional state, cultural beliefs, spiritual beliefs, their access to care, social support. You see how this will differ among even a simple thing as where you live. Attitude towards illness, which has to do with your culture, relationship with healthcare providers, and then the big discriminator, which is the economic situation of a patient. Here's the short list of what I think the value of identifying social determinants of health is. This could be, you all could probably tell me what this list is, but identify modifiable risks at the individual level, encourage and support certain behavior modifications. And Susan and one of her colleagues has put together a paper talking about how to talk to patients and what to talk to patients about when they have an environmental exposure. And then the idea would be to reduce the impact of any non-modifiable risk that non-modifiable at the individual level. Involve help, ancillary services, connect patients with resources. And what this results in is an enhancement in patient-centered care in the office, contextualizing that patient care. And I think it's well documented that a individualized approach, understanding a patient's limitations and abilities and what a patient can and can't do, and having a understanding with a patient increases at least adherence to your medical advice. And the patient's aware that you're attempting to have shared decision-making with any aspect of their care, partly because you model that when you're doing these environmental exposure questionnaires and caring about what their answers are. So what's the value of identifying social determinants of health? People say this all the time. It's highly relevant to our medical decision-making, the importance of understanding the patient as an individual, and making patient-centered and collaborative decisions with your patient. This is the result that we're seeking. Environmental exposure screening might be able to give us a leg up on this. And it's quite clear. And again, Saul Wiener's put together a series of papers that show that better health outcomes do result when practitioners identify and act on risk factors associated with these aspects of his patient's context. Screening for environmental exposures, screening for social determinants. Why can't we put these two together, at least in some way? So we're back in the office now. How can screening for environmental exposures add value to your own screening for social determinants, social, behavioral, contextual risk factors? What can you learn from that environmental exposure form and screening? And you have that in your packet. I hope you called it up. That might impact on a patient's adherence, patient's access to care, the stress, identifying underlying additional illness risk, based on some of the things that you talk about with your patients during screening. I believe that some critical information can be gleaned. And this information might be obvious to those of you who keep environmental justice in the forefront, but for the uninitiated practitioner, residents, students, young faculty, how can this environmental screening form inform critical patient context and social determinants of health? Now for a story. So it turns out that the uninitiated students showed us how. The backstory is, as a dutiful physician, I felt that a long time ago this was really important to screen for environmental threats. Our PACU wants us to impact on education and on the activities of our students, so our clerkship education group decided that we're going to give this task to our M3 students, usually in the preceptees in our office that we had relationships with. And listening to those students, we discovered anecdotally that they were a lot more invested in talking about the patient. Their presentations were richer. They seemed to understand their patients more. Their patients would smile at them if we were presenting in the room, and sometimes they'd add to the conversation. And they were enthusiastic when they put this into their plan. They were enthusiastic about the patient's context and how this might impact on their care. So all it takes is maybe develop a deeper understanding of context. But how did they do that? It turns out the students just begin to ask, well, how does this exposure occur in their unique experience, in the patient's unique experience? Because the patients were getting some extra benefit. We knew that. And so we thought what we would do is really give them a more explicit assignment. So we figured it was because students were asking why and how and getting to know their patients better. We assigned them to use the environmental screening form. We asked them to look at the context, that those 10 contextual influences. And we asked them, when you talk to a patient about these line items, which of these contextual influences might you gain more information about? What are the hints that you might get? Mostly when it comes to patients who said, yes, I have this exposure. But in general, we wanted to think a bit past that. The environmental exposure form that we used did address some of those. It gave you hints about how you should expand on answers. And then importantly, to discuss this with their preceptor. And that's where we got rich information about the patient. It helped us manage the patients. It helped the patients invite the students back in the room. Here are those 10 contextual influences. Here's the environmental screening form, and I altered it just slightly because here are the line items, and I asked the students to write corresponding context numbers, the ones that they thought might be relevant as they explore an exposure with a patient in the margin here. This is the second page, and here's what we get back. The important thing is to see this part. The pictures of all of you covers up the most important part here. I'm not sure how to show that. So move your pictures around a little bit, because on this last side are a bunch of numbers that students put in. Can anybody see that? Okay, maybe I'm the only one who's got this.
Yeah, I can see numbers.
Okay,
Yeah.
so that's what they did. And we looked at some results. And we took a sample of 43 patient encounters, and 74% of the times, students discovered useful information from expanding on the answers or expanding on some of the questions that patients addressed. And they found in 74% of the time at least one contextual aspect that might influence the care of the patient. That was we helped them identify when they talked to us about that. And a wide variety of those contextual areas was identified. And the utility of each question was high, we thought. So 75% of the 12 question topics on the environmental screening form were identified as relating in some way, worth talking about, relating to the context of the patient that could influence this patient's care. We decided this assignment might be a useful endeavor. Not only to introduce them to environmental exposure screening, but also to help improve patient care. And we asked them to think about questions in a non-threatening way. And getting into the topic of what's going on at home, what's going on in a community, what's going on in your life is sensitive. And students edge their way into most of these aspects of context of care through some of these environmental exposure questions. It's kind of a non-threatening way to discuss about things that are sometimes embarrassing, sometimes people are hesitant to talk about this. But they are real barriers to care. So to be fair, we did talk to students about environmental justice and contextual categories. And we know that the relationship of adverse environmental exposure and socially disadvantaged individuals is widely discussed. So I'll just read this from a great paper. Environmental hazards, exposures, risks are not uniformly distributed across populations. This is what we help the students learn. Multiple biological and social factors intersect to create unique exposures that in certain populations can disproportionately give them high risk of environmental diseases. And interplay of poverty, ethnicity, life stages, and pregnancy status is pervasive, complex, unfortunately, but well documented that these are aspects that impact on care. We felt like the attention that students paid to addressing these questions gave them a real opportunity to understand their patients. But also, I believe that, and we believe, the group in our education believed that this exercise had the potential for students to create empathy, create greater empathy, or perhaps contribute to the preservation of empathy among medical student learners. The literature on empathy is interesting. You guys have talked about empathy already in these presentations, but it degrades over time, and it degrades more quickly in residency, but it does degrade over time in medical school. So I was going to give us a participatory practice session, but as I figured we'd be running out of time, I'd like for you someday to access the form, select your favorite category of exposure, and then think about how experiences patients have would vary depending on how they get exposed. Let's say they had a positive result. how and why and when, and then consider what specific contextual challenges might be associated with which answers. For example, pesticide exposure from work, daily work from labor without PPE, and a day worker that Susan studied in the past suggests a different underlying context than exposure from squirting some Raid around the house. Another example, environmental lead exposure from renovation of your $3 million Lakeview home is a different underlying context than repeated unavoidable drinking fountain exposure at school. So some categories of exposure are more likely to provide valuable clues of their potential social determinants of health. What's the unique impact of unique patient context? It helps us know what a patient can do, what a patient can't do, what they can be expected to do, what's environmental, what's structural, what can they avoid, what can they not avoid. And here's a quote I liked, that health promotion programs lack clearly specified theoretical foundation or based on narrowly conceived conceptual models, and they emphasize focused behavior change while neglect the environmental underpinnings of health and illness. And this helps us also know what a provider can be expected to do, such as accessing other services and accessing a team, a village to help patients. You might say, can't do it. No, it's too hard. I'm too busy. They cut down the amount of time I can see with patients. So at least you can perhaps introduce this to your learners if you can't get it into your office as a construct. And if students participate in this and think about it, then maybe they will also emphasize, resist, deter students from the temptation to emphasize individual focused behavior change strategies and think about the environment and what a patient perhaps can't help, but that you can provide some service or some effort to reduce that impact. So refrain from always blaming the patient, another aspect of empathy. So try to raise the awareness of those around you if you can. And one way to do that and get a more bang for your buck is to use the environmental screening form and think about how those responses might matter to the patient and matter to your plan. Here are your 3 objectives. Justify the implementation of environmental exposure on the basis of impact of clinical care. I hope you got this question right. And then propose a plan to implement that environmental exposure questionnaire. I hope some of you are doing that. Well, what I've done in the offices that I've worked in is I've had them look at this form outside of my visit. And either I don't have anybody administer it to them because that too is work intensive. They read the form, they think about these exposures, and they come in either more aware of what to avoid, or they come in with some positive exposures that we have to explain and help. And this is something we've talked about, is you don't have all the answers, but you probably have some basic answers, and some of that is on the form. And then create the follow-up questions to explore these contextual challenges, to get to know your patients in a different kind of way, in a way that's unthreatening, but then help round out your understanding of this patient's microenvironment. I have some questions that my students have put together that I can circulate by email. So here are my hopes. This is an advocacy talk, not a scientific talk, although those were great. We want you to recognize the added value of environmental screening. We want you to teach and understand, address socio-behavioral determinants of health. Oh, by the way, last night in my mail, I saw the October 12th JAMA, which has 2 articles on the incorporation of social risk in USPSTF recommendations. I haven't read them yet, but they have great titles and they've got some great tables. So continue to advocate for environmental screening, raise awareness. Curiosity is the key when you determine the patient has an exposure. Try to reduce those environmental risks. reduced contextual barriers to care through patient-centered action, improve adherence, and ultimately improve health outcomes through informed patient-centered care, and consider that learners, other physicians, and maybe us can use this and develop an opportunity to be curious and to sustain the empathy, whatever empathy we have left after many years of practice. And Susan's next for more about environmental justice. Thanks.
Thank you very much, Gary. Round of applause. It's really interesting to go from the scientific BPA effect on the placenta to how to use an environmental exposure form. I'm hoping that Debbie, our coordinator, can put the link into the chat again to the e-materials that we've put together for you that include an exposure form. And I think using medical students is a great way to implement that exposure form in the clinic, as well as having the patients fill them out themselves, because we did make sure we put advice of what they can do if they answered yes, so they could read that too. Thanks very much. Okay, I'm going to go to my lead screen, now my lead talk, and before I do, I want to hold up to the camera, if you can pull up my screen. I suppose if you put in view the speaker view, which should go to me, not Gary, but I see Gary. But anyway, I'm holding up the little buttons that say, ask me about prenatal lead. And these are little buttons that that Alan Waltz from EPA mentioned there was a toolkit that he was putting together. So if you want some of these buttons that say, ask you about prenatal lead, ask me about prenatal lead, we can send those. And you might want to wear one once you, let me get the share screen, once we talk about screening for lead. So let's go to that. And I am not great about writing. I wasn't great about writing objectives, but I figured, okay, here's your objective. Here's the whole talk on the title screen. Screen your pregnant patients for lead exposure. So the objective is to talk you into screening your patients, your pregnant patients for lead exposure. I was looking at the chat. So the link now is in the chat. And, oops, sorry. I'm making the chat move. Let me get rid of the chat. All right. Sorry, my slides. There we go. Once again, the funders are the EPA and ATSDR, so we have to have a disclaimer and acknowledgements, and I don't have anything to, any conflicts. So we went from new exposures, BPS, and PFAS chemicals, now to ancient exposures, which is lead. It's still around, but it was first became an issue back in Roman times. So the Latin for lead is plumbus, and that's a big hunk of the soft, malleable metal there. And the lead poisoning was named plumbism. And that's why we call it plumbing, because the water pipes down on the bottom right is an ancient Roman water pipe. These were leaded pipes. So lead as an exposure has been around for a long time. The Romans used it to sweeten their wine. It's one theory that the fall of the Roman Empire was caused by lead poisoning. I'm just going to try to change my view here. I still have Gary on my view. Doesn't matter. Sorry about that. This slide I had to put in, this is very cool. Photo of a patient at Stroger Cook County Hospital, so the old Cook County Hospital, who was in industrial exposure to lead causing wrist drop. So very high lead levels cause neuropathy, and this was not uncommon in workers who worked with lead. One of the fun things about occupational medicine is everything you can learn from the history of exposures. So industrial exposure to lead in Illinois was first described by Alice Hamilton. If you haven't heard of her, she is considered the mother of occupational medicine in the US, and it used to be called industrial medicine. She went out to the factories in the Chicago area in Illinois, and these are some pictures of workers that were exposed to very high levels of lead. These are printers on the right, and the metal that they were printing on was a leaded metal. And she wrote a book and exposed the exposures. the high exposures to workers, not just to lead, but to others, but she started off with lead. And more recently, these are the sources of lead that we find in pregnancy, that we have run into more and more over the years as imported spices and imported products become more common. On the top left here are spices, and we recently had a family, the entire family was exposed to a turmeric spice that was contaminated with lead. The makeups of surma and coal can have lead. They're home remedies like Greta. Bottom right is pottery with pica in pregnancy, particularly. Women can eat parts of pottery, and we ran into this, both Gary and I ran into this when we were working on the near west side of Chicago, of immigrant populations bringing pottery up from Latin America, and when they had pica in pregnancy were exposed to lead from the leaded glaze. The picture in the middle is an exposure that our lead guru, Helen Binns, Dr. Helen Binns in Chicago, discovered in a teenager whose lead exposure, she could not figure out where the lead level was coming from, and finally tested the tongue stud and found that the tongue stud was leaded, and the acid in the saliva was leaching out the lead. And then the bottom left is stained glass. So stained glass is a home hobby that not uncommonly can cause high lead exposure because of the lead fumes that are used for the solder. So why do we care about lead exposure in pregnancy? Well, there is a 1-to-1 placental transfer of lead. And this is an old paper. Here is from 1977. I took a screenshot showing this nice slope of a 1-to-1 exposure of mother's maternal blood lead and placental cord blood lead, not placental, the cord blood lead. So 1-to-1 goes right through into the placenta. And then what happens with lead during pregnancy? This graph shows, this is divided into 4 trimesters. What they meant is prenatal is 0 and 4 is postnatal. And it shows what happens to lead as the pregnancy goes on. As you probably know, lead sequesters in bone. It can last there for 15 to 20 years. So even somebody who is not exposed to lead during pregnancy will bring out some of the lead in the bone, especially in the situation of low calcium, and that's what's also shown here. And in general, lead goes up during the 3rd trimester as the calcium is coming out of bone to prepare for nursing, and this graph shows that nicely. And it shows that women who have low calcium were bringing out more lead from the bone than women who received calcium supplementation. And this is a study from 2016 that used 3 different populations of patients. And then, so now we know that it goes across the placenta to the fetus. We know that it can come out of the bone during pregnancy, goes up in the 3rd trimester. Still, why do we care? This paper, sorry, it's a little blurry. It was a screenshot from the paper, but it brought together evidence from 3 different studies on health effects from lead exposure in pregnancy in the fetus, showing that on the column on the left, there's sufficient as evidence for an association between maternal lead and gestational hypertension and reduced fetal growth and low birth weight. And I think that the preeclampsia and hypertension study was one that Dr. Wiley was the co-author on. So you can see there's limited evidence. There is evidence, but it's limited, of preterm birth, etc., including ADHD and behavior problems in the young child. And then there's a hint of suggestion, but inadequate evidence about spontaneous abortions and depression and anxiety in children. And what I want to point out is these are effects of low lead levels. There's lots of evidence of problems with behavior, ADHD, in studies from the 90s when the lead levels were much higher than they are now. They're actually much lower now because of the turnover in our older housing. There's not as much paint exposure. So these data were taken from low-level lead exposure. So still having health effects from lead. And this is the last kind of evidence type of slide I'm going to show, just showing, and this was Bruce Lanphier was on this paper 2018. It was a meta-analysis of lead exposure and preeclampsia. And so you can see they clearly ordered them in by level of odds ratios, and being 0 showing no effect, and the studies showing an association between exposure to lead and preeclampsia. So there does seem to be pretty good evidence, according to this, of an association. After the child is born, I forgot I had this one in here. The prenatal lead exposure does affect neurodevelopment and decreases in IQ. And this has been shown in multiple epi studies. This particular study from 2000 was from Mexico, and the lead levels were pretty darn high. You can see there on the x-axis, the lead levels go up to 60, whereas mean today is around 1 or 2. So, but you can see the dramatic loss of IQ points even between lead levels in the mother between 0 and 10. And these were kids that were prenatally exposed and then tested at age 0 to 2 and 3 to 6 years. So this is just a representative graph of other studies that show decrements in IQ with prenatal lead exposure, which is why we want to avoid it. And so the CDC in 2010 created guidelines, and I'm always amazed when I talk to OB residents to ask them how many of them know about this, and they don't, which to me illustrates very well the gap between public health and clinical practice. And there's not a great communication between the two. So I'm letting you know, in 2010, the CDC came out with guidelines saying that pregnant women need to be checked for lead, screened for lead at their first prenatal visit. And if it's over 5, you need to counsel them. And this monograph also included recommendations for breastfeeding based on mother's blood level. In Illinois, there is a prenatal lead risk questionnaire on their available on their website, and you see here there are 10 different screening questions, which I've blown up on this page. A yes response to any of these questions should trigger a blood lead level. So Dr. Wiley and I were talking a little bit as we were planning this event about prenatal lead screening. And she was saying, clearly it's difficult to ask 10 questions just about lead, maybe just screen everybody for lead, and maybe we can talk about that a little bit. But the powers that be in public health say, here's the screening questions. Starting with, do you live in an old house? Have you ever been lead poisoned before? Do you live with somebody with an elevated level? Do you have pica? Have you had any oral piercings? So the tongue studs made it into this list, which was updated in 2018, I think. I think it was directly from Dr. Bin's case. Do you have any imported products that you've brought in? Do you have any hobbies in the house? And were you born outside the country if you spent any time outside the country in the past 12 months? I think this is a way to collect any types of immigrants who may have come from countries that still use leaded gas. And then do you have lead in your, do you know you have lead in your water? So once again, a yes to any of these questions should trigger a blood lead level. Now, this one kind of cracks me up because it's really busy, but it shows an algorithm that starts with the questionnaire and goes through the results of the questionnaire. And I did spend some time on this. It's not that complex. But what it does include here on the bottom left is what to do about the different lead levels. So if you can see in that venous blood lead level, you repeat it within 1 month if the lead level is between 5 and 14. And within 1 month, and then continue between 15 and 24, et cetera, et cetera. What I would add to that, if I had a patient with a lead level over 5, I want to find out what their exposure is. So not just this clinical management of following the lead level, but finding out the exposure with the help of the public health department, Those same guidelines from Illinois Department of Public Health do discuss breastfeeding. So breastfeeding is recommended to continue unless the lead level is over 40. So it really has to be quite high. And we would recommend pumping while the woman is chelated. And this was mentioned with PFAS too. It's a common question we get where breastfeeding is not, it's not recommended to stop breastfeeding according to particular levels of PFAS. So regarding breastfeeding, encourage breastfeeding if the person's lead is less than 40. Also very important for any pregnant woman with an elevated blood lead that you get a cord blood lead as soon as the infant is born, so you can find out what the infant's lead is and either chelate the infant or follow the lead over time if it's at a low level. This is a case where I would call medical toxicology for help if you needed chelation. And then once again, encouraging pumping and discarding for lead levels over 40. I just wanted to show you that ACOG as well has come out with a committee opinion on lead screening during pregnancy and lactation. And they have the recommendations there on a table on their committee opinion. Unfortunately, ACOG does not have a set of questions that they recommend. So, and also that CDC monograph does not have a particular set of questions. It's a little annoying, probably because there isn't enough data on which questions, you know, the validity of the different questions. But I showed you what the state of Illinois uses. The ACOG committee opinion lists a lot of different risk factors for lead in pregnancy. So you could create your own questions. And there are some other entities, shoot, I forget which, where there's some other, I think it was state of New York also has their own questions that they ask. So that was my last slide. I'm going to stop sharing for a moment. I'm going to check the chat. Okay.
While you check the chat,
Yes.
you distilled this down to 4 questions at some point, right?
Maybe.
Oh no, you don't remember either.
You know, I think we did because we were trying to get people to get it into the electronic health record.
Right, right.
And I think maybe we did.
We can send it out later if we remember.
I know, I'll have to look it up. So what I'm going to do, that's the end of my talk. And as part of a wrap up, I'm going to just go quickly over the PACEs so you know how we are available for you. So these are the 10 different regions. We've been talking about region 5. Dr. Wiley's from region 1. There is one center in each region that's staffed by physicians, nurses, toxicologists, hygienists, OBGYNs, industrial hygienists, so monitoring, people who can do air monitoring, OBGYNs, nurse midwives. And this is what we're funded to do. Look at the first one there, telephone consults to healthcare providers and families. So we are available to you to answer phone calls, any questions. We can do some clinic visits, but we don't have to. Clearly, we're supposed to cover the whole area. We do have expertise that we provide to public health and environmental agencies, and we do a lot of these trainings. Here's our group here in we call the Great Lakes Center for Reproductive Environmental Health. We've got a representative in each state in our region, and you can see Dr. Loy and Dr. Marie Cabilla are our 2 OBGYNs. And Debyante Porter there is our coordinator, and she's the one who you probably communicated with by email. The bottom left is our phone number and our hotline number, warm line, and our email address. I'm going to, just for in the matter of time, I'm going to skip some of these, but these are tools that we have on our website, steps to reduce exposures in the home with some nice graphics. We have a handbook on how communities themselves can find out about their exposures. So if someone says, I'm living near a trash dump, landfill, I don't know if it's contaminating my water. I think there's a couple kids in my child's school with cancer. Is there something in the air in our neighborhood? This guide shows people how they can find out for themselves what their exposures are in their areas. We've got a blog that's really written at the level of pretty much for anybody, because I know that the healthcare providers don't learn this stuff. So it's really for anybody who wants to read more about the effects of exposures. All right, post-test, the last thing we're going to do. What I'd like you to do is put in the chat. How am I going to, wait, can I see the chat at the same time I'm seeing the slides? Yes, there we go. So put in the chat the answers to these questions as you get them. What pregnancy complication has been most linked with PFAS exposure? A, stillbirth. B, anencephaly and other neural tube defects. C, preeclampsia, hypertensive disorders of pregnancy. D, cholestasis of pregnancy. So I wasn't sophisticated enough to get the polling thing set up, but put in the chat what your answer is to this question. Thank you very much. Looks like we're getting some answers that all look correct. We've got C, preeclampsia, hypertensive disorders of pregnancy. The next one is not moving. What is the potential impact of implementation of the environmental exposure questionnaire in the office? A, identification and mitigation of hazardous reproductive environmental exposures. B, improvement of patient adherence through patient-centered management plans. Improvement of patient health outcomes through incorporating context into management planning for C. D, giving physicians and students who use the form opportunity to sustain or develop empathy. E, all of the above. Okay, Gary, I thought that one was a little easy. Looks good, looks good. I think Gary made a good case for all of those. Did I skip? Okay, here's the next one. Select all the true statements. A, humans are inevitably exposed to a mixture of chemicals on a regular basis. B, some endocrine disrupting chemicals such as bisphenols can reach fetal circulation. C, the epidermal growth factor pathway is not involved in modulating human placental function. D, gestational exposures to the chemical bisphenol S can impair placental function. So which ones are true? Thank you. Looks like you guys are on top of it. C is the one that was not correct, because we clearly saw that that epidermal growth factor was involved in human placental function and was affected by bisphenol S. This last one is, which of the following is true regarding maternal blood lead during pregnancy? Very little crosses the placenta on a 5-to-1 ratio. The action level is 15 micrograms per deciliter. C, it does not cross into breast milk. D, may be elevated by pica. Which one is true? I think I didn't mention breast milk. I'm sorry about that, but we did talk about stopping breastfeeding if the lead level was too high, clearly because it crosses. So thank you very much for getting this one right. D, it may be elevated with pica when women eat or chew on pottery that has leaded glaze. Okay, great. Thank you very much for the post-test. I want to remind you that to fill out the CME form, I think Marilyn did put a link to that in the chat. I'm wondering, Marilyn, if you could put the link for the CME again. Now, the residents that are here, you will receive $50 as an incentive for being here. We're still figuring out how UIC will allow us to do that, whether it's a gift card or cash, but we are going to get you $50. And tell all your other friend residents that we'll do it again next year and they can get $50 for coming. I want to thank our speakers. It's been really great hearing from everybody. Please use the electronic resources. And we've got there, yeah, I see we've got the Qualtrics CME evaluation link. And I think that's the end of my announcements. Thanks everybody for coming.